Welcome everyone. Thank you so much for coming along today. Hi to everyone joining the live stream. We're gathering today because the new CFS guideline from the National Institute for Health and Care Excellence has finally been published. And we wanted to create an opportunity to ask some of those people who have been involved in developing it some questions, which is so exciting. We're so grateful to have them here. This is your chance to delve into a bit more depth around the guideline, ask those questions about the processes that were undertaken, or find out what these committee members we've got with us today see as the most noteworthy recommendations in the guideline. For example, you could ask how they see care for people with ME changing, or what they think the next steps are now that the guideline is published. I'm Karima. I'm a volunteer with ME Action Scotland and help out with the UK sometimes too, and I've been doing that for a few years now. I have ME myself, but fortunately quite mild, probably, as you can tell, and I'm also delighted to be hosting with Sian today.
So hello everyone, my name is Sian and I've been volunteering with ME Action UK for 3-4 years now. Time flies. So I'm really excited to be here today with Caroline and Adam and everyone who's joining us. So we are recording this, but only the speakers will be visible on the recording. And we're also live streaming it to Facebook. So hello to everyone who's watching on Facebook. Again, you won't be visible unless you're actually speaking. We've got a chat box here on BlueJeans. Hopefully you can hover over your screen and click chat in the top right corner if you're on a desktop, or elsewhere if you're on a mobile or tablet. And we'd love you to put questions into that chat box, please. You can also ask questions on the Facebook chat, and we've got someone with us to funnel those questions through to us. So yeah, back to you, Karima.
Yep, and we'd also like to introduce Malcolm, who'll be keeping an eye on the BlueJeans chat box, and that you just said, Sian, sorry, that Laurie's keeping an eye on the questions coming through the Facebook chat. So Sian and I will aim to put as many of your questions to Adam and Caroline as possible in the time that we have, which is obviously just the hour. So first up, Adam Lowe is a person with ME, a poet and writer who has worked extensively with LGBTQ+ youth. Prior to his appointment as a member of the Guideline Committee, he was an active supporter of various ME organisations, including ME Action UK, Science for ME and more. Along with 4 other lay members, he's played a vital role in ensuring the voices of people with ME were always heard in this process, and we're so delighted to have him with us today.
And then Karima, that's a lovely introduction.
And then we also have Caroline Kingdon with us. She is a registered nurse and research fellow. Since 2013, she's been working for Cure ME on the UK ME CFS Biobank based at the London School of Hygiene and Tropical Medicine. She's been responsible for recruiting participants, including visited severely affected people with ME at home, in order to help include them in the project, and has used this experience to guide her input to the guideline. So thank you for joining us, Caroline.
It's a pleasure. Lovely to be here.
So we're going to head straight into the questions. We wanted to first ask how much time and energy you've had to put into this over the past 3 years. We know the guideline was originally intended to take roughly 2 years to develop, and this has been longer for many reasons. So how much work has this been for you both? Caroline, I'll go to you first.
Yes, I think if I'd known at the beginning, I might have been more hesitant to be so keen, because it is an enormous amount of work. There's an awful lot of background reading to do. And I started off by printing all the documents off, and I'd end up with a pile this thick. So I soon gave up on that. But everything is very carefully done so that you have time to look at things, you have time to go back to things if you need to. There's lots of open discussion, so it's a really interesting process to be part of, but yes, very time consuming.
How about you, Adam? How have you found it?
Yeah, well, I mean, so I was at the initial stakeholder engagement workshops as well, which were in 2017. So for me, it's been the best part of 4 years. So it's been an incredibly long time, an incredible amount of reading. I quite enjoy, reading up on ME research, but when you've got sort of 4,000 pages of literature reviews and things to go through, that is quite a lot. And the evidence review that you guys see, which I think is 900 pages, that is just the final draft of it, but we saw multiple drafts of that, so we had to read the 900 pages several times over. So my nickname for it was War and Pace, because it was so big.
Love that.
And it was quite appropriate as a name.
Yeah, definitely. That's great. Thank you so much. And just getting across a peak of what must have just been an enormous process for you both to go through. The next question is coming via email from Pamela. I think it's one lots of us are wondering. The development of the NICE MECFS guideline has been followed with interest around the world, as many of these guidelines are. What advice would you give to those from other countries who are seeking to develop their own guideline? Who wants to jump in first?
I'll go. I was waiting for Caroline, but I assumed that she was being polite and thought, no, I'll let Adam speak because he's got first-hand experience. Yeah, so I mean, I think the important thing to learn from this is that actually you can get a committee that has a broad range of experiences that includes the patient voice. You can actually listen to patients, you know, that might be a surprise for some researchers in the past, but you can actually listen to them and involve them in that decision making. And I strongly believe that the lay members played a really valuable role in that process, and we were all listened to. And because there were 5 of us, there's normally only 2, sometimes up to 4, but very rarely. But because there were 5 of us, it meant that if one person was ill or they couldn't make it for whatever reason, it meant that there were other people that could pick up the slack. And I think for something like ME, where people, you know, will have fluctuating symptoms and they can't guarantee that they can always be there, that is super important. And I think part of that is making that process accessible as well, because NICE were very, very thorough in making sure that all of our needs were met. Like, they would check that the lighting was okay in the room. They got us like recliner chairs to sit in for the in the rooms. We had like these little lap desk things that you could put on your lap so that you could work on your lap if you wanted to sit in one of the recliner chairs. They had all the meetings in the hotel where we all stayed. We could come the night before and leave the day after. We had extra long lunches and extra breaks so that we could lie down in the middle of the day if we needed to. They went above and beyond. They also gave us an allowance for carers to join us, which was hugely valuable. My husband came for most of those meetings, and I don't think I would have, you know, been able to make that journey down to London on my own so many times without his help. So I think listening to the patients, having them involved, being inclusive, that is really, really, really valuable, and having that breadth of experience. You know, if the only people who are creating the clinical guideline all come from the same profession, then that might be, you know, a bit of a problem. And in the past, we've seen that that has led to very one-sided and biased guidelines.
Absolutely. Thank you. That's amazing to hear you. It shouldn't be amazing, but it's amazing to hear you talk about that access requirement being met, and really, you know, that understanding of the needs that patients might have, and that's what needs to happen in order to include them properly. And it's a richer guideline because of it. That's great. Caroline, did you have anything you wanted to add?
Well, I guess from my point of view, obviously I was meeting with a lot of new clinicians. I think the patient voice was actually the most important voice we had there, because if you haven't had ME, you can conjecture what it must be like, but you don't really know. So I think that was so valuable. But then it was also really interesting to have the clinical contribution coming from people who had very different viewpoints at the beginning, and it was working together and trying to find common ground without giving into things where we thought we actually had to hold out and had to be absolutely sure that those weren't included or were included as part of the guideline. So it was a fascinating process. You know, I think for a social anthropologist it would be fascinating to actually watch the process. And I remember when I was interviewed for the guideline, they asked me specifically, what would you do if you were in a room full of people who all disagreed with you? And I thought, oh gosh, that'll never happen. But of course, there were times when it did happen, and we had to work through that. And I think that the NICE moderators were terribly helpful, because they would sort of bring us all to our senses and help facilitate the meeting going forward. But it was certainly a fascinating process.
That
It
sounds
sounds, yeah, absolutely amazing. We've got a question that goes into quite a specific ask next, which is from Lolita in Denmark. And she says, in the new guideline, there's a recommendation that says, do not offer people with ME/CFS physical activity or exercise programs that are based on deconditioning and exercise avoidance theories as perpetuating ME/CFS. So could you explain to us what is the meaning of exercise avoidance theories, and how did the NICE committee agree to use that particular expression?
So I know the answer to this one, because we talked about it a little bit. In the draft, it actually said exercise intolerance first, and then it was exercise intolerance and avoidance, and then it just became exercise avoidance. And essentially, that is the wording that was used in things like the PACE trial and GetSet. In those trials, when they described graded exercise therapy, they said this is based on the deconditioning and exercise intolerance theories of ME. They initially used the terminology exercise intolerance, but then by the time it had come to GetSet, it became exercise intolerance and avoidance. Now, the avoidance was always crucial within that model, because the intolerance, in their viewpoint, came because we didn't do enough, exercise, we didn't do enough activity, and that made us kind of hypersensitive to any activity. And in their view, the intolerance was just a lack of fitness, So we were very careful about the terminology, because we knew that we could only refer to the clinical trials that we looked at. We had to be specific about what we were talking about, and that was the theory that was in there, and it was really important to us that we actually denounce that theory now, because that theory has been a prevailing theory in many clinics for 30 years or so, and yet they've never been able to produce conclusive evidence that it works or that it's accurate. And actually, some might say there's a lot of evidence that these things don't work. And so the time had come to say goodbye to the deconditioning and exercise intolerance / avoidance model of ME.
That's great, thank you. Yeah, and I think there's a little insight into actually, what we've seen, the huge amount of research, the huge amount of conversation, discussion, everything that goes behind the guideline, and then so the specifics of that language that you guys have gone through with some of that, in that actually it has been that all those different things, and we have thought it all through, and it's a very hard balance to strike sometimes, I'm sure. I've got a question now from Rebecca, who said that as people with ME are often not supported or believed by their GPs and other professionals, Rebecca would like to know if there is anything that's being done to push the guidelines out to the medical professionals through their channels, so NICE's channels, courses, or education, kind of any next steps for their process.
So would you like me to answer this one to start, Adam? So something like this is obviously valuable, although it doesn't tend to reach the physicians who don't consider ME/CFS to be a real disease. But we are trying to publish. Interestingly, NICE often publishes something in the BMJ, but in this case, nothing has been published yet, the actual NICE committee. So we are trying to get things published as committee members to get the information out there. Nina Muirhead, who many of you may have heard of, has a big education program, which is initiates out of Cardiff, but is goes all over the UK. And she is very much trying to push for education, not just for GPs and hospital physicians, but also for nurses. So she is part of a nursing group for nurses in ME. So that's the problem is, and Elora Finley, who was on the committee with us, who is a GP herself, explained that in medical school, you probably get only a couple of hours to do ME/CFS in the whole of your medical school training. And you've got to make sure it's the right person delivering that program and somebody who really understands the disease. So I don't think that this is going to happen in a heartbeat. And I think it's really, really important that we don't let up. Okay, the guidelines have been published, but there's still a lot of room for actually making sure that they're fully implemented, and particularly in terms of education. So certainly, I don't know about you, Adam, but I'm accepting anyone who asks me to do anything that might be educational in any way. I'm saying yes. And I'm sure you're the same way.
Yeah, exactly. I think the education part is going to be a huge task, but I think this is where the role for our charities comes in. I know that ME Action have been really, really good at getting information out there, screenings of unrest, doing events where they invite people to come and talk, and that has always been really, really useful. I know that the ME Association now has a magazine that it sends out to clinicians. I saw the first ever one the other week. So I think that there are things that are happening, perhaps slowly, but things will potentially be changing on that front. And I know that NICE is very keen to see take up of the new guideline and to see education. So they, are still in continuing conversation with stakeholders about how they might do that and how they might get the word out. So I know that that's an ongoing process, and they have been in touch with, charities and clinics and things like that to see how they can get that information out of there. What might be helpful as well, and I'm crossing my fingers, is that BACME, which is the British Association for CFS ME, maybe they'll become BAMKey, maybe, now that it's ME CFS. They have officially endorsed the guideline and said that they can work with it, and it seems that they've had a change in a lot of their personnel. So because BACME represents, the clinics as they are, they also seem to be involved in a lot of the training. So if BACME are backing the guideline and they're willing to use it in their training, then that could be an avenue in future. It might mean that things become better, and we might start to have better relationships between the patient groups and the clinics, and that can only be a benefit, I think, but it will take time. And as Caroline says, there are going to be people who don't believe that ME is a thing. There are going to be people who disagree with the guideline and think that it was biased, and I've listened to whatever headlines that have put their negative spin on it and believe that, or they've had certain people whisper in their ear, so they believe those whispers, and those people, it's going to be much more difficult, but in time I would like to think that each new generation that comes along is going to learn from the next one, and maybe all those people who are hanging on to the old models and the old way of doing things, maybe they won't be in the position to do the training next time. So next time round it might be the good people, the people who get ME and understand it, and so with any luck that means that in future things will continue to get better. And I see it as a process that one change could then start another, and it's a bit like a domino effect. So with any luck, things will continue to get better.
Exactly, and that's the thing is that we hope we continue to work, and that those people that we aren't, we know we're not going to change their minds overnight, but they will become the minority with outdated views, because we have this which is completely backed by evidence. And yes, I absolutely agree with you. We know it's going to be a big part of ME Action's work in the time going ahead, and I think we know we're coming together with other charities and patient orgs as well, and thinking about, okay, now we have this, what can we do about it, because it will be there's still work to do from here. Sean, do you want to take the next question?
Yeah, I've got another question. This one comes from Caroline and her daughter Holly, who has had moderate to severe ME since the age of 12 and has had an awful time. Struggled with hospital admissions and not everyone believing her, and coming out being kind of even weaker and frailer. So the question is, why is ME still so stigmatized in 2021? Why does nobody believe the devastation it causes?
I think the main, shall I go first? This one.
Yeah, go on,
I think the main problem is that we don't have a diagnostic tool. We can't give people a blood test or take an X-ray or do a scan and say, I saw it, that's ME. And I think that's a huge problem for people, particularly in this day and age. And I don't know how many of you have noticed, but there's also a stigma around long COVID. A lot of people don't want to say they've got long COVID. There's been quite a lot in the press, certainly in France. Is long COVID really a disease, or are people malingering? So we shouldn't be surprised by that, bearing in mind the history of ME. I think that the tightening up of the diagnostic criteria can only be helpful. So by saying that post-exertional malaise is a key symptom for ME/CFS, I think is critical, because I do think there have been times in the past when ME/CFS might have been confused with depression. And then if you treat the person with depression with exercise and CBT, they miraculously get better. And I think perhaps there's been some sloppiness about the correct diagnosis. So I do think the diagnostic criteria will help. And I think, again, this is a job for the charities, for people in education, in research, for clinicians, to actually educate their peers, their colleagues, and the general public about ME/CFS. And I think there has been a lot of positive press, along with the bits of somewhat negative press, that will help that. I do hear more and more from people who perhaps used to be sceptical, that now they're beginning to wonder whether it is actually something real, particularly when they hear of someone with long COVID, which exhibits so many of the same symptoms and follows a virus.
Yeah, I'd agree with that. I think many of us have felt that complex frustration of seeing people talking about long COVID like it's a brand new thing, and obviously have immense compassion and care for those people going through that. But it's been a strange time, and I think we'll probably come up again later. But we've got some questions coming through on the Blue Jeans chat now, which is great. Thank you so much. Oh, sorry, Adam. Thank you very much.
Yeah. I mean, I was just gonna to follow up from what Caroline said about the diagnostic criteria. I think one of the weaknesses previously was that because it was basically a list of, a whole bunch of symptoms, and you only needed to have one or two and then a mixture of any others, it did become, in some people's minds, a kind of wastebasket diagnosis of, oh, well, we don't know what it is, just chuck them in there. And I think partly the reason of having a succinct and concise criteria that ask for, for specific symptoms, and it's the symptoms that, when combined, had the highest prevalence of separating people with ME from people without. So that's why we chose those four. It does create a clearer clinical picture, and then it allows people, I think, to think, oh yeah, I can visualize that now as an actual illness. I don't just see it as this loose collection of, oh well, that could be, that could be anything, that, because, and I could say that I've got ME. That's probably the attitude that a lot of people may have had in the medical profession before. But there is one more point that I wanted to bring up, which is the just world fallacy. So for those who don't know what that means, the just world fallacy means that if you are good and you try hard, then good things will come to you, and you won't get sick and things like that. And the flip side of that is that a lot of people want to believe that because it gives them a sense of control over the world. But it means that when people become ill, especially when it's chronic illness that doesn't go away, people start to think, oh well, they must have done something wrong to become ill. Like, I would never become ill like that because I work too hard. I strive to be better. I look after myself. I wouldn't succumb to the weakness of that illness. So the just world fallacy, which a lot of people don't realize that they have as an unconscious bias, that is the thing that actually works against us, because a lot of the time they see these people that are ill for a very long time. There's no other explanation for it, and so people think, oh well, it must therefore be their own fault. It must be a deficiency in their personality or their coping mechanisms or their behaviour, and that's what's caused it.
That's really interesting. Thank you for sharing that, Adam. I'm not sure I've heard it phrased in that way before, but we see it all the time, with that messaging of that guilt and onus on the patient, when that is, doesn't make any sense. None of us want to be.
Exactly.
And thank you so much. I'm sorry for cutting across you. I'm very glad you're the kind of person who will jump in and make sure that you can say what you want.
I did that a lot in the NICE guideline, don't you worry.
So I will move on if you guys don't have anything else. So Jan has asked one that I think we've probably got a lot of people wondering, and I know that you guys will have given some thought to, is do you have any concerns that graded exercise therapy or its equivalent will carry on being used, given that the guideline pathway recommends that physical exercise can be part of the treatment for ME/CFS?
Yeah, it was a really tricky one. Many of us didn't want the word exercise in there at all, but there was this lingering argument that if we do not mention exercise at all and a clinician goes to look for it, then will they just offer exercise off their own because there's nothing in the guideline about it? So at first, the initial draft, we didn't have exercise in there at all. And then, it did come in for that reason. And partly that was because, we felt that we needed to outline what absolutely shouldn't be in an exercise program to make it clear. But also because, pragmatically, we knew that these clinics were going to have to do something, we're going to have to continue. And realistically, there was a lot of pushback from, rehab and physiotherapists and saying, oh, this is just going to make everybody kind of worse and they'll weaken and so on and so forth. So what I thought was important was that if exercise is in there, that we describe what it absolutely shouldn't be, and that we put in place some protections for the patients. So a lot of people miss this, but in section 111, it does say that any exercise program must be done within your limits. So it's not about pushing the boundaries and, going beyond, but there is actually, a clause in those recommendations to say that it is supposed to follow that model of staying within your limits and not triggering post-exertional malaise. And that's a really crucial element, because without that, obviously then graded exercise therapy comes back in. And so I think some clinics will try to keep pushing graded exercise therapy and change the name, because we know that some people, think that they're God or think that they know better than anyone else, and they will do that, and that is part, unfortunately, of human behaviour. But now that those protections are in the guideline, I would strongly recommend that people read that section, read all the little details, and then highlight that bit that says not to go beyond your limits. Because if you are getting offered that from a clinic, you can say, well, look, the NICE guideline says you shouldn't be doing this, and you can put in a complaint. You can complain to PALS. Hopefully in the future there will be some reporting mechanism for reporting harms, but it does give us a little bit more control and a little bit more say in what's happening, because we now have that recourse. We can now say the official guideline is on our side for once, and it says this.
Absolutely. Caroline, do you have anything to add to that?
No, I think Adam explained that beautifully. I mean, it was really difficult, and we did go back and forth about how to include this. But I think it is very important that you realise that bit of the guideline right at the beginning is there, and that you can show that to people who are offering you what you think is an appropriate treatment. Sorry.
So we'll go on to our next question, which is going back to the long COVID topic. And Fran has asked in the chat box, saying that NICE seems to have withdrawn its advice to not use GET in long COVID. But I wonder whether you could expand on that at all, and expand on whether you, as a committee, had any contact with the long COVID committee, or whether there was total separation there, and what you think. If you've got anything more to say about what the impact of long COVID is having on ME and vice versa.
So no, we didn't give any input into the long COVID guidelines, as far as I'm aware. I don't know if people did as individuals, but certainly as a committee, we were kept very, very distanced from it, which I think is appropriate, because I think it still probably is early, and actually it's quite devastating if you have got long COVID to be told that you've got ME/CFS. So I think that people have to be pretty sure before they give that diagnosis. It does seem that the two diseases are very, very similar, but I think the scientists certainly are being pretty cautious at the moment. And there's lots and lots of research going on. Again, it's so difficult because if you could see a biological change in ME/CFS, or we do see small immunological changes, small changes in cytokines. It's it's not the kind of test you can do at the GP or at a regular hospital clinic. And until the in-depth research can actually show that there are really similar changes, it does seem that they are similar diseases, but I don't think that anyone would come out at the moment and say that they are just the same. What would you say, Adam?
Yeah, it's really tricky because I think there are a cluster of illnesses that look very similar. There's people talk about chronic Lyme disease and Gulf War illness, for example, as having overlap with ME. But for example, Gulf War illness, some of the research that's done by Nancy Klimatz looks like it actually means that it's slightly different, and actually in ways that ME things are down-regulated, those things are up-regulated in Gulf War illness and vice versa. So I think it is really difficult to kind of clump everybody together and say that they're definitely the same, although I think that we can definitely learn from each other. And I think because those patients are saying that they have post-exertional malaise, we do have to listen to that. So I think in regards to the long COVID guideline, we did offer to input into that, but NICE chose not to take us up on that offer. I suppose the argument would have been that they wanted an independent committee and that it wouldn't be a conflict of interest. So they brought extra people in order to do that, and they did put a warning on that guideline to say that the recommendations for ME/CFS shouldn't be considered to be applicable to long COVID, specifically around graded exercise therapy. I hadn't noticed that had gone, but I imagine that if it has gone, it's probably because the guideline has changed. It's no longer CG53, and it no longer recommends graded exercise therapy. So there would be no need to have a note on the long COVID guideline saying ignore CG53 because graded exercise therapy may not be appropriate, if that makes sense. So that might be why they've done that.
Yeah, that does make sense, and that's really useful insight and just really interesting to hear you both discuss that kind of potential overlap. And I know it's something that many of us have been wondering about. So Susan has asked another one that I'm sure many of us are thinking is, how confident are you both that the recommendations for both access to an ME specialist team and a social care assessment for people with ME will actually be implemented, and we'll see that for people who need it?
Well, confident is probably not the right word, but hopeful. NICE guidelines are supposed to be followed by resources, so that if they say this is what's required, in time, those positions will be resourced. However, I think it's very, very difficult that it's at this particular time that the guidelines come out, because with COVID so prominent and the terrific pressures on our health service, I am hopeful rather than confident.
Yeah, and I think, you can't guess what's going to happen tomorrow. Like, the government might decide to sell off the NHS tomorrow, and then, none of what we've said in the NICE guideline matters, because you have loads of private companies essentially running, an even more fragmented service than we currently have. And NICE has no power to force people to do things. However, I would say, and I've been advising everybody the same thing, if there is guidance, and there is best practice guidance, and a clinician chooses not to follow that and it leads to harm, then there is a very strong legal case against that person. Because if you go to court and you say, I harmed this person, but I was following the best the best practice, you know, it wasn't my fault, then a judge is, you know, or a jury is way more likely to kind of accept that explanation, and it's not going to get to that situation where you're culpable. Whereas if you've purposefully chosen to go against the recommendations, the best practice guidelines, then you open yourself up to liability. There may also be liability in terms of insurance. Like, insurance companies might say, actually, we're not going to cover you for this malpractice because it's your fault because you didn't follow, you know, the nationally recommended guidelines. So there are things in there, and I know that's not the best situation, that people have to be harmed before it changes things, but again, there are protections. And I would like to think as well, CCGs usually fund things based on what NICE recommends, and it is a lot harder to go against those and say, I want to do a service that is completely opposed to the NICE guidelines. Whereas in theory, it should be a lot simpler to say, we want extra resources in order to do this. And one of the lifelines that, you know, that we did give to clinics, because we were aware that somebody has to deliver all of this, somebody has to implement this guideline, and we can't always be opposed forever with the clinics, even if we were in the past. Part of the lifeline that we offered them is that actually you're going to get increased funding now. You're going to be able to increase the time that you run your clinics, because many of the clinics run for only 1, 2 or 3 days a week, which is obviously not enough to deal with a complex condition like ME and to treat it properly. So in having this beefed up section of the guideline, they in theory should be able to ask for more time, more money, and, you know, then hopefully be able to deliver on that. So no one can force them to do it, but I would like to think that they can see the opportunities that are there and that they will, you know, take that on. Because if it was me and I had to split my time 2 days a week doing a clinic for ME and then 3 days doing various other things, I would like to think I would like to do it full time, or have a bit more focus and a bit more resources, so that you didn't feel as strained and stressed and that you were stretched so thin.
I wonder if you might also say a bit about the multidisciplinary team, Adam, because I know that the recommendations around that have changed, and that might impact how clinics work too.
Yeah, exactly. So the multidisciplinary team is now much more expanded as well. So it was very difficult finding evidence for what a multidisciplinary team should be. It was easy to find evidence saying, oh, we should have multidisciplinary teams, but what that actually was much more difficult. But what we ended up doing was listing all the different skill sets that we thought should be within a multidisciplinary team. There was a bit of discussion about whether it's better to list professions, but we knew that we wouldn't necessarily find agreement there, because some people would want some professions in and not others. But we also thought, actually, we need to future-proof the guideline, and sometimes roles change and different things come in. So we thought there is no reason really why someone with the right training who can deliver that skill set shouldn't be able to deliver it just because they've not got the right terminology. For example, there are now nurses who can prescribe independently and various things like that. So maybe they could fulfill a role that previously could have only been dealt with by someone else. So if you look at the MDT section, that's multidisciplinary team, we actually go through all the different things that you need. So there's medical assessment and diagnosis. The word medical is important there because it suggests a physician or a GP. Developing personalised care and support plans. So that is someone who can, you know, come up with the management plan, the treatment plan, the care and support plan, but can also oversee it. Again, that kind of suggests you might want a physician or a GP to coordinate care. Things like people to do self-management strategies, symptom management, including prescribing and medicine management. So again, that requires either a doctor of some kind, that might be a GP, a physician, a psychiatrist, but it could also be a prescribing nurse. And then, you know, they need to be able to manage things like flare-ups and relapses, and diet and nutrition, things like falling, access to aids, so social care and support, and then supporting work, education, social activities and hobbies. So that's really, really broad. And if you think about the clinics that we normally have, you have maybe a doctor who diagnoses you, Then you get passed to either a CBT therapist. They're not always a psychologist. Quite often it's just, a cognitive behavioural therapist. And then maybe you'll go to physiotherapist for graded exercise therapy, or, activity management. And there's not a lot of input there. Some sometimes have a dietitian or they'll refer you elsewhere. But by having all of that within that multidisciplinary team, those clinics get more funding, so they become bigger and they have more capacity. But it does mean that we can start looking at all those other areas. And then in theory, we should be able to do things like offering greater support, and making sure that people's needs and adaptations are met.
Yeah, no, I think that section has got real potential for helping change things in the future. Caroline, is there anything you'd like to add, or should I go on to the next question?
No, just to say that I think it's very positive, because ME/CFS is such a complex disease, and really you need to draw on all those different resources. And for some people, it might be the dietitian who's the most important person within that team, and for others, it could be the cognitive behavioural therapist, for example. If you're diagnosed with ME/CFS and your life is restricted, that has a real impact on your quality of life. And in the same way as if you're diagnosed with cancer or diagnosed with diabetes, you have to come to terms with that, and that can be really difficult. So in that case, the cognitive behavioural therapist would be there to support you going through this terrific change and this acceptance of perhaps a different lifestyle, which may continue over a long period of time. So I think that all the members of that team are important, and we did fight very hard for there to be proper medical representation, because we felt very strongly that the diagnosis should be made by a doctor.
Yeah, that's fantastic. So the next question that we've got is from Mark, and he says, have you got any suggestions for how local groups might persuade specialist clinics to abandon the previous approach and adopt the new guideline?
Well, there's nothing like getting together and talking, so maybe invite them to come to a meeting. That might be something to do. Whether they'd accept or not would be a different thing. I think, as Adam pointed out before, actually appearing at a clinic with the guideline and showing what, the things that you're unhappy about, that you feel aren't being followed, the trouble is that you're an individual there, and it's quite difficult if you're the patient and the protester. So I think, trying to use intermediaries is probably a good idea. But I think dialogue is the most important thing, and pointing people to some of the educational resources that are available. Natalie Bolton's series of videos. Now, if you can get someone to sit down and watch some of those, they're actually very powerful. They are a bit long, so you've got to find someone who's committed to watching them. But if you can find a chink in the armour of a clinic and go in there and try to educate people, I think that would be helpful. But it is a problem.
Absolutely.
I agree, and I think that there are things that we can do. I know that people have been calling it out on Twitter, hashtag, GetWatch. People have been telling me, on Twitter about their local clinics. So I think that the charities, the national charities, are trying to do things as well. I think don't be afraid to form networks with people and team up with people, because it makes it a lot easier, and there's no reason why you can't go to ME Action UK or go to the ME Association and say, look, our clinic is still doing this, can you help us? Because the strength in numbers, as Caroline says, and I think that a lot of the clinics will change in time. I think it may just be a matter of waiting and seeing. I know that's not always what people want to hear, because people, we all want the change to happen yesterday, basically. But especially when people have been in that intolerable situation of having waited for so long and not engaged with healthcare for so long, it does seem like I've waited 20 years, I can't wait another year of my life. But I think things will slowly change there, and I think everybody just needs to come together, call it out, make a stink about it, write to the CCG, you know, do that I'm going to speak to your manager thing. That often works, I find.
Oh, you've just gone silent for me, Adam.
With
But
each other. Yeah.
Oh, I think you're coming back. You dropped out a bit there, Adam, so I'm not sure.
Oh, is it me? Sorry. Which part
Oh,
did I drop out at?
The last couple of sentences.
Okay, I think I was just saying, you know, it's easier if there's teamwork. So try to team up with other people that are doing things, reach out to the national charities, and that should make it easier, I think.
And I think that multi-pronged approach has real power, and that's definitely something ME Action UK are up for engaging in. So do send us emails on uk@meaction.net if you've got ideas and thoughts and want to see if there's places we can collaborate.
And I think, you know, it's quite difficult for the people who had the beliefs that they were doing the right thing. So I think also understanding that is maybe helpful. It's very, you know, as a patient who's received a treatment that's been harmful, obviously you feel very angry, very frustrated, very hurt, very impotent. But I don't believe there are many doctors, physios, psychiatrists, whomever, not many anyway, there possibly are some, who really think that they are offering something in order to harm the person that they're treating. Yeah. So I think it's just a lack of acknowledging the patient experience, a lack of listening to the people that they're treating, which has stopped them from learning and moving on from these harmful treatments. But obviously one hopes that there aren't people working in clinics who really think that they're offering a treatment that's going to harm someone. So I think that's important, a certain sensitivity in understanding where they're coming from as well, because it's like when you're doing something with a child that you're bringing up and someone tells you you're doing it all wrong. You know, you have to be quite careful about how you do it, because actually mum or dad thinks they're doing the right thing. So I just hesitantly put that point.
Yeah, you don't want to further entrench people within those positions as well. I mean, a number of people had asked me whether I'd reached out to those members of the committee who previously had you know, espoused biopsychosocial, you know, models of the illness, to bring them over into the fold. But I imagine that there is a certain amount of sting and a bit of cognitive dissonance as well when, you know, the thing that you've believed for so long and have invested so much of your time and effort into is actually maybe not the correct method. I think what may be a better option is for some of those people to be proper allies, is to let them kind of go away, and then when they're away from the shame and the guilt and the embarrassment, they can then just pretend, oh well, I was always that way, and they can suddenly change on their own. But I think if you push them, sometimes it worsens that guilt and that shame and that embarrassment, and actually it makes them more likely to you know, defend their position and say, well, actually no, I think I'm right. And sometimes it becomes harder then to make them allies.
That's interesting, thanks. And I think, you know, we do know and hope that extremity is the minority, and actually we know there's been a dearth of good support, guidance, and information, so that, you know, we have a bit more behind us now. So our next question is from Darren, and they've asked, what else would you have hoped the new guidelines to have included but that weren't included this time around? I know.
Well, yeah, there's probably loads of things. I mean, it does say in the rationale to the guidelines, so that the longer section towards the end, it does say that diagnosis is usually done by a doctor, and that's a sort of explanation to go with the MDT section where we talk about the different expertises there. But we struggled to get the word doctor specifically into that part of the guideline, you know, in the actual recs rather than the rationale. And I would have quite liked that in there at certain places, because I think if every clinic had to be led by a physician or a GP, for example, it would force the NHS to train those people, for starters. And if they're new people, then they won't necessarily have all of that baggage that's come along before. And it would also mean that you would then have more capable people who are able to look at all these different elements, because physicians are, trained, and GPs are trained to look at the kind of the whole person. And so I think that would have been really, really valuable. There's probably lots of other things as well that I wish were in there. I wish certain things had been clearer, for example, but that's the one that stands out to me off the top of my head.
Yes, I'd agree. And I think quite a lot of people have found some drugs helpful, but unfortunately there wasn't enough evidence to recommend anything specifically. So I think that points to the need for more research in those fields, more people being involved in studies. We realised how important it was to have really robust studies, because unless you can produce the evidence, anecdotal stuff just isn't good enough, and tiny studies don't meet the criteria, and studies where the diagnostic criteria are fuzzy and woolly, they don't work either. So again, I think that the charities are very good at looking at these what's going on in research and actually being very objective about it. Because sometimes as a researcher, I think you just get carried away and you can't see the wood for the trees. And so I think working with people with ME/CFS is really important, and also having charities and other organisations looking at what you're doing. Putting in a grant proposal is a sure way to find the flaws in what you were thinking of doing.
I think that's a fascinating insight, and hopefully this guideline will boost all of the charities' work and others' work to improve research and get that research funding there. And I think the kind of clearer statements that there isn't a cure for ME creates that impetus to do that. We've got a big thank you for the hard work that you guys have done, Adam and Caroline. Let's come invite you, Mel. So thank you for that. And a question that says, why do you think NICE paused the publication of the guideline instead of discussing the Medical Royal College's objections after publication? And was this the right approach, since many patients felt in limbo and let down?
So I answered this question already with David Tuller, but I will recap for those who didn't watch that video on Virology blog. So my theory is, because we didn't actually know until it basically happened, until they paused it. But from what I understand, there were the objections that were raised by the Royal Colleges and NHS England and Improvement. But I think there was also at the same time hints that there would be a massive negative press campaign, time to come out with the guideline. And what would have happened is, if the guideline had gone out on the day of publication, which was 18th of August, I think, all those articles that were lined up would have gone out. It would have been all over the media smearing the guideline. And so for the next 10 years, we would have had to deal with all of that kind of negativity, and it would have potentially lost all of the good messages that were in there. And so I think I was very confused as well, and very upset when it happened, just like everybody else, because I didn't understand why. But as time went on, I kind of realised what had happened. And I think I realised why NICE weren't 100% transparent about it as well, because I think if they had said to the Royal Colleges, we're getting you to a meeting to set you up so you can basically reveal how stupid you are in front of everyone, the Royal Colleges wouldn't have gone. Do you see what I mean? So they needed to make the Royal Colleges think that they could actually affect a shift in the guideline, that they would have some power and some say to get them into that meeting, because all they needed to do, and I know that NICE did this very well, is just defend the rigour of the guideline, and all the arguments suddenly seemed to dissolve. So some of the Royal Colleges who were opposed, some of the groups actually stood down and said, all right, we're going to back it now. Others just fell quiet. And then all those articles that had been planned for that day, the editors had to decide whether to scrap them and move on with something else, or whether to pause them. And then NICE gave very little notice when they actually finally did publish the guideline. So there wasn't a lot of time for everybody to kind of get back on the bandwagon of slagging it off. So I think we potentially averted a lot of negativity by pausing it. And from what I've seen, most of the coverage, the news coverage, was really positive, and it was on message. And they could turn around now and say, look, we have got support now. We had a roundtable. We did listen to people, and that actually strengthened the position. So most of the news coverage was positive, and the negative stuff was very, very minor. And I think now those people who are still complaining, they just look like these extreme, viewpoints, people that just need to get over it because everybody else has moved on. And I think that's really, really clever. And in a way that has benefited the guidelines. So yeah, I wasn't happy with it at the time, but I think in hindsight and as it was progressing, I think it turned out to be the right decision.
Would you agree with that, Caroline?
Yes, I would. I mean, I was not only upset, I was furious because it seemed to go against all nice principles of, being objective and listening to the committee, and all those things just seem to have been thrown away in an instant. But I think they were very clever in the way that Adam has outlined. And I think that in the end, when they came out, the negative press was minimal, to be honest. And it was almost as if it was passé. And of course, these were the guidelines and we must just move on with them. It's interesting. I wonder what you felt as an organisation when they did actually come out, because you must have monitored the press. I mean, it's different when you're involved.
Many of the similar things that you guys have described, I think shock initially. We heard a few hours before we had a big press campaign set up and ready to go, and all of that. So, but looking back on it, knowing from one of the people who went along to the round table that was a really positive event, and that felt like there was really good discussion and dialogue there, which is what you talked about earlier, Caroline, that dialogue is just so important. I think that NICE did quite well in many ways. So it was an interesting time and a difficult time for many. So very aware of that. But I think we have got to a very good point now to move forwards.
Yeah, really interesting to hear that insight from both of you. Thank you, because I think many of us, it was an extremely emotional time that I've struggled to have any distance from. So that's very helpful.
I know exactly what you mean, Karima.
We are going to just stay on the more controversial aspects of it for a moment, and Mark has asked if you can comment on why 3 members of the guideline committee resigned.
I don't think we can, actually. I think, I don't know whether you feel able to, Adam, but...
Well, we weren't really given much information, but it wasn't to do with the meetings of everything was agreed in those meetings. So the idea that there were mass resignations because people couldn't agree and it was so fraught and everything, that is not my experience. And as I understand it, there may have been some personal matters and some other things going on that were the precipitating events for those. So I think that the media story of the committee not reaching consensus and it being torn apart, it just wasn't true. And if it were true, you would expect a lot more resignations, because there were a lot of the colleagues of the people who left still on the guideline who were willing to back it and support it. So I don't know why those people left, but I think that they were under a lot of pressure from outside influences, people who were determined to have their way and were quite rude about it, to be honest. And there were other things going on. So I don't really think that it was anything to do with anybody on the committee or disagreements in that sense. I think it's their personal situations, and I would leave that up to them if they want to explain why.
Absolutely. And it was interesting to see in the minutes from the round table that Peter Barry, who was chair of the guideline, did make it clear at the beginning of that round table event that the resignations had happened after consensus was reached around the guidelines and not before. So we've got We're going to go with 2 more questions. I know there's loads more that people have wanted to ask, and we just don't have time. So we're gonna overrun a little bit. I hope that's okay with everyone. This is being recorded and it is on Facebook. So if you're at the end of your energy limits, please don't feel you have to stay to watch this, because there will be another chance. But we'll go for 2 more questions and then we'll round up. So this one is from Susie, and she asks, how do you think the guidelines will be applied to those who had previously been diagnosed, sometimes many years ago? Do you think that we will undergo any more testing listed in the guideline to confirm our ME diagnosis? Do you think we will have access to specialist services?
So as far as the confirming diagnosis goes, the tests don't confirm diagnosis. The tests rule out other diagnoses. So I think that's really a really important difference. So I think if people feel that they're unsure about their diagnosis, then I think this is a good time to re-present at the GP and say, I don't think I was ever screened for thyroid, I'll go through the list. But they aren't offering a diagnosis of ME/CFS. They're not confirming the diagnosis. They are excluding other diagnoses. And obviously it can be very useful to know, for example, that you're anemic, because that can be treated, but they aren't confirming ME/CFS. I think that's just one important thing to say.
So the testing is confirming ME/CFS, but hopefully the diagnostic criteria that you've laid out.
Those are what are important. So you need a really good clinician. And unfortunately, it's an art that's rapidly being lost by GPs who love the tests and aren't so keen on actually examining the patient. And particularly, of course, COVID has exacerbated that as well. So that's a difficult thing. Yeah.
And it might require more time in an appointment as well to go through the history and identify, all of the symptoms. And we did go into quite a lot of detail, I think, on a lot of the symptoms. So, there should be more of a guide. It should be less of, oh, this person feels a bit worse after exercise. We'll say that they've got ME. Like we go into, well, it's usually delayed. It's disproportionate to the activity that happened. Various things like that, so that it becomes clearer what we are looking for. And I think that's really important. But I would also hope, because you will notice, and this is one of the things that I'm quite pleased about, is that for severe patients, it's 6-month checkups, I think, and then for everybody else, it's 1 year. So every year, you're supposed to be getting a review. And that's really important, because if you've got new symptoms, if there's anything that's changed, if that diagnosis no longer feels like it fits, that should be the time that you are able to come back and do those things. And I think there'll be a lot of people who won't have seen a GP for years, but now might be the time to come back while this is all fresh in people's minds, while they've read about it in the news, to come back and say, and I've not had a yearly checkup for 20 years. Can I arrange something and see what happens? Hopefully that would catch things that have been missed, or of course, additional diagnoses, because just because you have ME, it doesn't mean you can't have other things as well. And I've got a long shopping list, and I think most people with ME tend to have more than one thing, going on. And so that's important to bear in mind as well.
Great, thank you. So I think we are going to do a last question. And a nice one to really reflect on what you were sort of saying at the beginning of this, Adam, that what we have really seen is a level of patient involvement here that is to be commended. And so we're wondering, how can we ensure the level of patient involvement seen in this process is replicated elsewhere in research and other arenas?
Caroline, you might be best placed to answer that one.
Yeah, so it's interesting now. If we apply for a grant, or if we write a paper, we actually have to talk about how the patient group has been involved in that piece of research. And I think this is becoming, people are realising that it's so important to try to get the viewpoint of the person who actually has the the disease. And I think that's something that's been neglected over many, many years. So certainly people like the NIH, many of the major journals are insisting that there is participatory involvement so that patients are there and are represented and their voices heard. Personally, I think it's absolutely crucial because the best way to learn, and I still get brought up short by things that people tell me because we go on learning. It is such a complex illness. And I think that it's so important that the patient voice is represented. And as I say, it was the most powerful voice on the committee, very definitely. We couldn't have been without it.
And hopefully, you know, people will be able to fall back on this and say, well, look, this is how they did it for the NICE guideline. This is the best practice. You know, let's do this going forward. So I would hope that things are changing for the better, and that we continue to see more patient involvement. But obviously, we have to be engaged with that as well to make sure that people stay on it, because I think if you let things slide, things can go backwards. And so it's really important that national and local charities remain alert and remain vigilant, and you know, they take some of that, they take on some of the slack so they can make sure that people are doing what needs to be done, so that if there is a bit of a slide back, they can kind of catch it.
Yes.
But we have seen, haven't we, that other groups are trying to do more to include patients as well.
And that's the thing, we've shown it, well, you've shown it's possible now, and that, you know, what we can get out of it and how much richer that is. So it's excellent to have that. So last thing before we wrap up is just say, is there anything else that either of you wanted to add, or any closing remarks that you wanted to give?
Well, it's on much the same theme, but I think a huge thank you to patients, especially those who were on the committee. I mean, those meetings were endless sometimes. They weren't always terribly exciting. They went on and on and on. There was an awful lot to take up in, even if you were functioning completely normally, if that's possible. So for those people, it was a huge investment of time and effort. So I think that is really to be celebrated. And just to say, you know, continue, let researchers know, let medics know, tell them things, because that's the only way people learn more about it. And I think that's so important. And when I get an email from somebody, you know, describing something, it really makes me sit up and think, I wonder why, I wonder how, I wonder, you know, and I think that needs to be done, because it is still such I don't like unexplained, because then I think of MUS, but it's still an illness and a disease that we don't know what the root cause is. We can see some changes, but we don't really know. We won't be able to effect a cure until we do. So the more information the patient can provide, I think the more we'll progress, and the more quickly we'll progress. But huge thank you to patients.
Absolutely. So I'm going to take a second to do a tiny bit of promo. We've got a Dear Doctor campaign at the moment, and if you go to meaction.net and search for Dear Doctor, you'll find a template that you email that you can send to your GP that talks about the new guideline and ask them to read it. We've had some really positive responses from people who have sent this already, saying that their GP's clinic has got back to them saying, yep, they're going to include it in their monthly kind of roundup that they do with all their GPs. So it's really worthwhile doing, and it's just that multi-pronged approach again of, you know, it's the patient voice and it's everyone getting involved in disseminating this out there. If you guys have a minute, and Caroline, this one applies to you as well, there's also a survey out from the Priority Setting Partnership for MECFS at the moment.
Yes, I saw that.
Which is really a great one to do. It's open until the 13th of December, so you've got a couple of weeks left to do it. And it asks you to prioritise your top 10 research priorities in MECFS. And yeah, we're asking healthcare professionals who work with people with ME to do that too. So anything you can do to get that out to healthcare professionals, please do.
Great, thanks. So did you want to say anything else, Adam?
Well, I think Caroline covered it really well. I mean, I just want to say thank you to all the charities that kind of supported us. Thank you to NICE for, making us included within that process. And I know that a lot of people contributed a lot and gave a lot of their own energy to the guideline. Loads of people sent me, private emails saying, this is my experience of being at the clinic. A lot of local groups sent me surveys of their patient groups so that I could see, what was going on the ground. And that was all really, really invaluable. And I know that it used up a lot of really valuable energy that people didn't necessarily have. And I think all of that contributed to where we are now. So, yeah, thank you, everyone.
And we're really seeing that thanks coming straight back to you guys. There are so many comments in the chat right now giving that real heartfelt thanks to both of you, Adam and Caroline. You know that we at ME Action are so grateful for your work and the huge amount of energy, time and attention that you gave this over many years. And so that is us. Thank you so much also for giving up your time now. It continues even though the guideline is out. And big thanks to Malcolm and Laurie for making all the tech happen in the background and getting your questions to us. Huge thanks to all of you for attending, for engaging with this, for being interested and for just being so tireless in your work to advocate for yourselves and others, and for giving us your energy and time today. As always, please keep in touch with us on social media. I know there's been some stuff happening in the chat. My brain can't cope with both of them right now, but there will be recordings. This is also on Facebook. There will be ways for you to catch up on this, watch it again, and remind yourself of what's happened here. So best way is to follow us on social media. You can sign up for our emails as well on the ME Action website. And of course, if you can donate, it helps make all of this happen and continue our efforts. So that's us. Thank you so much for tuning in. It's been great to be here with you all.
Thank you, everyone. It's been really fab to have you here. Thank you, Caroline. Thank you, Adam.
Thank you for inviting us.
Thank you for having me.
Bye.
Yeah.
Bye, everyone.
Bye.